Hello, everybody, and welcome back. My name is Teresa Amaral, and I'm really happy to be here with you again on this Medscape Melanoma series. So, in our last episode, we discussed about biomarkers and the importance of biomarkers, especially in the adjuvant setting. And I hope you enjoyed the presentation, also the discussion. And today I'm going to show you why it is important to have these biomarkers in the adjuvant setting. And one of the reasons that we need to have these biomarkers and we need to better select the patients that need or should be recommended to receive adjuvant therapy is because we still don't know what are the patients that would benefit from adjuvant therapy. And also, what should be the patients that should receive adjuvant therapy based on the data that were presented recently about neoadjuvant therapy in patients with microscopic disease. And on that topic, and because this discussion it's a very important one that's been gone for quite some time, me and my colleagues we decided to look into this question and to write about it. And today I'm going to bring you a little bit about our reflections on where are we going to move next in terms of adjuvant immunotherapy in patients with melanoma. So, the title of this manuscript of this publication is Adjuvant Immunotherapy in the Modern Management of Resectable Melanoma, Current Status and Outlook to 2028. And the reason why it's 2028, you will understand in a couple of seconds. This piece was published in ESMO Open and it's an open access, so you can look into that and make your own conclusions about what we discuss here. So, the first question is who are the patients that are candidates for adjuvant therapy in the era of neoadjuvant therapy? And first of all, we will have patients that have a macroscopic disease, and macroscopic disease has been defined as a disease that we can see clinically by inspecting the body of the patient, but also disease that can be seen using radiological assessments like ultrasound, MRI, CT, PET CT, etc. These patients will, in principle, be candidates for receiving neoadjuvant therapy because we have seen that patients that have this type of disease and receive neoadjuvant therapy have a better outcome than patients that receive adjuvant therapy alone. Still, there will be a significant proportion of patients that are diagnosed with stage 3B or higher that are not candidates for neoadjuvant therapy because they have what we call microscopic disease. And what is this microscopic disease? It's disease that is present, but we cannot detect it clinically or radiologically, which means that in this case, we most likely will propose a sentinel lymph node biopsy to these patients, and this sentinel lymph node biopsy, or even removing more than one lymph node, will show in the pathology that these patients indeed have a metastatic disease that is not seen using only clinical assessment. And these patients, as I said before, will be candidates for adjuvant therapy, but not for neoadjuvant therapy. So, how many are these patients that will be candidates for adjuvant therapy, but not neoadjuvant therapy? And we looked into these numbers, and most likely these numbers will vary depending on the country that we are looking for or we are looking into. But it should be around 40% based on the registries, the national registries that we have, for which we have data for. These patients will be the ones that will be candidates to receive adjuvant therapy and might be more depending on how we define macroscopic disease. Moreover, there will be patients that are diagnosed with stage 3A and patients with stage 2B and 2C that will still be candidates for adjuvant therapy and at this time point not candidates for neoadjuvant therapy, although there are some trials investigating a neoadjuvant therapy also in this setting. Finally, we will have patients that have been treated with neoadjuvant therapy that have then, after that, been received surgical resection. And for those that didn't have a major pathological response, most likely we will also provide adjuvant therapy for these. So in the end, we will have a group of patients with different characteristics that will be candidates for adjuvant therapy, but not for neoadjuvant therapy. So, why were these adjuvant therapies approved? For those that are less familiar with adjuvant therapy in melanoma, these therapies were approved initially for stage 3 in 2018 2019, pembrolizumab for stage 3, and nivolumab for stage 3 and stage 4. And then later on in 2022 and 2023, the immunotherapy was approved for stage 2B and stage 2C, not in all countries, but in a significant amount of countries, at least in Europe. These therapies are obviously currently part of the discussion in terms of adjuvant therapy between the patients and their physicians, and it should be discussed with the patients based on the benefit that they can provide. All of these therapies were approved based on a benefit that is benefit in terms of relapse-free survival and distant metastasis-free survival that favors the therapy with PD-1 versus placebo, which was what was tested in these trials. These therapies provided a benefit that was associated with a risk reduction of approximately 40%, considering a combined endpoint that was a combined event defined by recurrence or death as a combination.